shirts. If you have any questions about Nami, the things we do here on the Western Slope, please feel free to ask myself or any of our volunteers. My name is Heather Nara. I'm the Vice President of our local chapter and Events Coordinator for Nami Western Slope. So I'm just very happy that you've taken the time today, for whatever reason that you're here today to learn more. We are going to have a time of question and answer afterwards, so if you have questions, feel free to keep those tucked into your mind. And today we're actually going to be hearing from a psychologist as well as from two individuals who live with mental illness. So we wanted to give different perspectives and different information about bipolar and schizophrenia. So we're excited for what's going to be shared today. We do have information in this back room over here. So afterwards, feel free to take some time. Nami Western Slope offers a number of programs for individuals living with mental illness as well as their family members. So if you have questions about our programs, again, feel free to ask our volunteers, and we'll be happy to let you know what we have going on. We've got some classes coming up. We've always got monthly support groups. So there's a lot to offer to you. So I'm going to introduce our first speaker. So we're going to sort of talk about one brain disorder and then have an individual share about that, and then we'll move on to the next brain disorder. And so Dr. Dave Jacobs is an assistant professor at Colorado Mesa University and in the psychology department, and he's going to be sharing with us from the psychology perspective, and then I'll introduce our individuals when it's their time. Always, if this triggers anything, brings up anything for you, you sort of need to excuse yourself or would like to talk to somebody, feel free to go back in this room. We'll have some of our volunteers back there. Sometimes this can bring back some memories or some things that have gone on in your own life, so we want to make sure that you take care of yourself today, and we'd be happy to help you do that. So we'll let Jake take it away.
All right, so as Heather said, I'm a psychologist and a professor at Colorado Mesa. And I kind of want to give you a little bit of a background of where I'm coming from concerning these mental disorders. You know, I've been working in the field of mental health for a little over 10 years now. So I started when I was pretty young, when I was still getting my undergraduate education. I started off working in an inpatient mental hospital with severely mentally ill people. And my job literally consisted of getting people out, helping them brush their teeth, helping them get dressed for the day. And through the last 10 years, I've really worked my way up through the field from the very entry-level position to now a psychologist. And I do have a private practice here in Grand Junction where I work with several juveniles that have been incarcerated here in town at the detention center. So I feel like I've worked from the ground up, and I've also worked with a lot of different populations. I've had the great opportunity to work from everywhere from kids to older adults with end-of-life issues. So I feel like professionally I have a very broad perspective on mental illness because I have had so many jobs and have worked in so many different environments. Now the other part is, I think, the personal piece, and a lot of us involved with Nami knows that. And, I'm like everybody else probably in this room and most of the people in the United States, in that I have dealt with mental health issues in my family, with friends, and in my own life. But today, you know, I'm going to be mainly coming from a scientific perspective, and I want you to realize what I'm going to be promoting and what I'm going to be speaking about today. I'm going to try to be neutral and present it in this is what research has told us. This is the purely scientific facts that we know now. And you will see once we get into these disorders that we know a lot. We don't know as much as we would like about a lot of these disorders, but we do have a pretty good grasp on some of them. All right? Okay, so the first one I want to talk about is bipolar disorders, and I think a lot of us, I always tell people, you know, I teach the abnormal psychology class at Colorado Mesa, and this is the disorder. I've been teaching it for years now, and this is the disorders that are most misunderstood of any disorder I teach. The students there ask me more about these disorders, and they always say at the end of the class, and that, wow, you know, I had a really big misconception of what bipolar is, and you know, I really like that aspect of the class. Now, bipolar disorders is actually a class of disorders. There's not just one bipolar disorder. It's a class of disorders, and we diagnose those based on severity and how long hypomanic and manic symptoms last, and we're going to talk about exactly what those are. But this class of disorders, and you'll see references to the DSM, and those of you who follow mental health news have probably seen in the news that the DSM-5 is out. Now what the DSM is the Diagnostic and Statistical Manual, and it's basically just a list of all of those mental disorders and the criteria for each of them and the symptoms. And it's what doctors use, psychologists, is what we use to diagnose. Now, this bipolar disorders are actually 3 different disorders. It's bipolar 1, bipolar 2, and then one called cyclothymia, which I'm guessing probably nobody in here has ever heard of that one, because it is very rare, but it is a classifiable mental illness. So we diagnose these disorders. The main sign is when we see hypomanic or manic symptoms. And what are these symptoms that we're talking about? Well, we can break the symptoms of bipolar and of the mania and hypomania that make this up into 4 different categories. And the first category is affective, or I like to say emotional. So what are the emotional effects of bipolar? And we see that this is what's usually how it's explained. People will say it's elevated, expansive, and irritable mood. A lot of words to say that you have a high mood, or that you're actually in a really good mood. What we would call an extremely good mood. And we know that the DSM-5, which just came out 2 weeks ago, they have added changes in activity and energy to one of those symptoms of bipolar. So we really see that these 2 things here are the main symptoms of bipolar. If any of those 3 disorders we've talked about is an elevated, expansive mood with changes in activity and energy. And we know that, one of the symptoms is it impairs socially, our interactions with others, impairs our work. And then we see here some boundless energy, enthusiasm. Some people report feeling high when they're having mania. And those are the affective symptoms. And then we have our other 3 categories, which are cognitive, behavioral, and physiological. So when we say cognitive, we're meaning thoughts. And we notice a distinct change in people's thoughts when they have bipolar, when an episode of mania has happened. So we talk about, flightiness, which is just, a word for not being able to stay on topic for very long. Pressured thoughts, which means you have a lot of thoughts in your head, and you have so many thoughts in your head that you can't sort them out. Poor judgment. These are the cognitive, the thinking changes that we see. Behaviorally, we see, uninhibited. Now, another point I want to make is that when we're dealing with these symptoms, realize that when doctors and when I'm diagnosing these, or you're going to a doctor, is that there's a list of symptoms of all of these symptoms we're going over. Now, that does not mean that somebody with bipolar has to meet every one of those symptoms. Actually, it's kind of opposite. We know that people with bipolar, people with mental illness, everybody's experience is different with that mental illness. So, if I have bipolar, I could have, a lot of the cognitive symptoms and maybe just one of these physiological ones, whereas somebody else could have tons of these, all the physiological and just one of the cognitive. Does that make sense? So, not everybody has all of these symptoms, but we all have some. Anybody with bipolar has some of them. Okay. So, and we see, things like, and I said that before I got to the impulsive sexual activity. Impulse shopping, abusive discourse, and then these are the behavioral, and you can see the differences between hypomania and mania. Now, I've been talking about these manic, they call them manic episodes, which is a period of time, a discrete period of time where you have these symptoms. And that's, mania is, they say full-blown mania, and you can see some of these behavioral characteristics of that. Now, hypomania is, I like to refer to a lesser form of mania, or baby mania, as one of my students call it, and they said that's how they remembered it. It is you are still getting the high mood, but it's not as severe, usually doesn't last as long, and usually behavior is a little more controllable than you would think with mania. this distinction is pretty important because when we get into talking about the types of bipolar, whether you have mania or hypomania really defines what type of bipolar you have. And you can see these physiological changes also: decreased need for sleep, increased heart rate, and sweat. And remember, these symptoms are all happening over a discrete period of time, usually anywhere from 2 to 4 weeks. Okay. Oh, we've thrown away. And here are our types. And you know, bipolar 1, which is what I think most of us are familiar with. This is what we see in the media. This is what's portrayed on TV shows and movies. It is when you have at least one manic episode. So you have had one episode of 2 to 4 weeks of those symptoms that we described. And now notice, with or without a history of major depression. Now, a lot of people think that in order to have bipolar, you have to have depression and mania. That is not true. As we can see here, is that you can have just mania, and you can have bipolar 1 and have never had depression. And then we have bipolar 2, which is, the way I separate them, thinking bipolar 1 is the manic one, bipolar 2 is the one that's more to do with depression. And bipolar 2 is somebody that they've had depression, and they've had at least one hypomanic. So what we see is that patients with bipolar 1, mania is the main thing that we report wanting help with, that they have problems with. Bipolar 2, they talk more about depression, and depression is the thing that is causing more of the problems. And then we have cyclothymia, which is, you know, you never have mania, you never have depression, but you do have a lot of, you have hypomania, and then you have a lot of the symptoms of depression, but you don't meet the full criteria for depression. So in this one, it's considered a little longer lasting. For at least 2 years, you can see that this happens. So I think of this one as this is kind of, you've been like this for a long time, and it's not something that comes and goes, cyclothymia. And cyclothymia is much rarer than the first two. Now, notice up here, you can't have mixed episodes. So a mixed episode is when you have depression and mania at the same time. So instead of having alternating periods, which is what the majority of people bipolar have, you have depression and mania at the same time. And you know, at time comes depression. We could talk about depression for days, and we're not going to get into that much today because I really want us to focus more on the mania part of it. All right. So I got these this morning. So these statistics came from the National Institute of Mental Health's website about 4 hours ago. And this is the United States, so we're not talking about the world here, we're just talking about the United States. If we look at this, you know, they talk about lifetime prevalence. So this means over our lifetime of all of us in here, about 4% of the U.S. population will suffer from bipolar, one of their bipolar disorder. And then we can see that 83% of those cases, 82.9, 83, are severe, meaning that it will require some type of urgent medical care at some point. So this is one of the highest, when we talk about mental health disorders, bipolar has one of the highest rates of being severe. The percentage of people who have bipolar who we would classify as severe is one of the highest. And then you can see the age ranges here, 18 to 29. We see that that's kind of, that's that key stage. So when the majority of people are being diagnosed with bipolar from the time of 18 to 29. And then you can see it steadily goes down as we age. So one good thing about getting older is the risk of bipolar goes down, right? All right, so just some interesting facts. We know that 25 is the average age of onset. So for the majority of people, 25 is about when they're first diagnosed with bipolar. There are no gender differences in bipolar 1, but we know that bipolar 2 is more frequent in women. And that, I think, really reflects the fact that depression is also much more common in women. And if we remember, bipolar 2 is more of the depression form of bipolar. We know that symptoms usually lessens with age, with or without treatment. So that's kind And then we know that there's a lot of comorbid, which means there's a lot of other disorders that are associated with bipolar. And this is the one that really stood out for me, is that about 50% of people with bipolar disorder will struggle with some type of addiction to a substance at one point, and that includes cigarettes. So we're talking cigarettes, alcohol, cocaine, anything. And we also know that health-wise, people with bipolar also visit the doctor more for health reasons, and some of this is there's an increased risk of hypertension, cardiovascular disease, and diabetes. And we're going to talk about why that is here very shortly. And then, 15 to 19% die from suicide. So we're looking at about 1.5 to 2 people out of 10 people die from suicide. Okay, so now I want to shift gears a little bit. We kind of got the basics, some facts. Now I want to get into the causes of bipolar. And this is where we really get into what is it that's causing, what do we know so far with our research? Now, you've got to realize that research in mental health, we're, at least 150 years behind the rest of the body. And one of the reasons for that is because we had no way to look into somebody's brain without, cracking their skull open and poking around, which not really recommended. Until, the 80s came along and MRI machines came along, we really didn't have anything to do it. So if you look at the majority of our psychological research, all of it is from the 1980s and up, when we talk biologically, because we finally got the technology. So new stuff is coming out every day. We do know that bipolar is passed down through families. We do know it's heritable, and we see it pretty strong. It's actually the most heritable mental disorder that exists that we know. And this is a pretty strong indication that 72% concordance rate for identical twins. So you got two identical twins, separated at birth. One grows up in California, one grows up in New York. They never meet each other. If one of them has bipolar, 72% chance the other one's going to have bipolar. So we look at that and we say, well, they grew up in two different environments. They don't know each other, so it has to be biological. And then, we know that if your mother has bipolar, there's a 50% chance that you can have it. And the question I always get is, well, what about the dad? Well, the dad, no, it's the other one, but the dad, it goes down to like 15%. And that's actually one of the things we're researching now, is why is it so much to do with the mother and not the father. But we also, so based off of these findings, they looked at genes, and we're doing all this human genome mapping and everything now, and they have identified several genes that are related to this disorder that are passed down. The main one they have been looking at right now is this one. It's got a real long fancy name, but we can abbreviate it to CR2. It is a gene that is related to the circadian rhythm. And a lot of us have probably heard of circadian. I'm from the South, so I might say things a little weird. But circadian rhythm, that's also our sleep cycles, right? It has to do with our brain waves, and it has to do with, our sleep cycles. And this is the main gene associated with that, and we've also found that to be the main gene associated with bipolar. So now, it won't be just that gene. This is as far as we've gotten, but I guarantee you they'll end up finding 50, 60, 70 genes that are associated with passing this disorder. All right, some other things that we know is that it has to do with how the brain communicates. We see some real biological differences between the brain of someone who doesn't have bipolar when we compare it to somebody who does have bipolar. And these are, now what I'm talking about here is that the way our brain communicates is, to simplify it really quickly, is it's through electricity and it's through neurotransmitters, which are basically just chemicals in the brain. So whenever I have a thought, as you all are sitting here hopefully paying attention and listening, your brain, there's electrical activity going on, right? And inside one of our neurons, we have an electrical impulse in our brain. We have millions of neurons in our brain. And there's an electrical impulse, and that electrical impulse signals that neuron to release a neurotransmitter. And what that neurotransmitter does is it travels across a little space in our brain and is absorbed by another neuron. And that sends signal to signal. And this is happening in nanoseconds, millions and millions of times as we're sitting here. And that is how our brain communicates. So in order for our brain to work correctly, we have to have the right amount of electricity and voltage, and we have to have the right amount of neurotransmitters. Because if that electrical signal happens and that neuron releases, serotonin, which is a neurotransmitter, if it releases too much serotonin, then the message is not communicated correctly. If it releases too little, it's not communicated correctly. And this is where a lot of our research for all of our mental health disorders has honed in on. And this is what we have found for bipolar. For the depression part of bipolar, we know that if you have low serotonin and low norepinephrine, then that usually leads to depression. Now, norepinephrine, it might sound familiar to some of you. Anybody, when you go to a truck stop and you see like the little yellow jackets and those pills that are designed to keep you awake, those are synthetic forms of norepinephrine. So norepinephrine is what makes us go, gives us energy, keeps us up, also involved in sleep. So we're starting to see a theme here with sleep and bipolar too. So we know when both are low, we have depression. And then with low serotonin and high norepinephrine, we see mania. So when we measure those brains, and that's what we see when we look at the brain during those different things. And we know that when we have low serotonin and high norepinephrine, parts of the brain get overactivated, meaning that parts of the brain start working harder than what we know they should be. And then we know that dysregulation in brain activation systems, what happens is parts of the brain start working harder than what they should be. So the guy, I like to say this, the guy next to that part of the brain, or that part of the brain that's next to the part of the brain that's working too hard, well, they say, well, that part of the brain's doing all the work, so I'm just going to sit back and have a cup of coffee. So that part of the brain doesn't do its job and is not working enough. So it leads to dysregulation in all of our brains. So it kind of sends our brain into haywire, where we have some parts working overtime, some parts not working at all, and it contributes to that imbalance. Now, the other thing it does is disruptions in the HPA axis. Now, simply the HPA axis is what controls our stress response biologically. So any of us, maybe coming here today to a new environment is stressful, and we might have a stress reaction. We might have to take a few deep breaths, and we're calm and we're not shaking like that. Well, we know that when these neurotransmitters get out of whack, it's a lot harder to control our stress response. So when you have bipolar, it's literally harder to control your stress physically than it would be for someone who does not. And that's across the board for just about any mental illness that we see, is that we see it biologically in the brain and in the central nervous system. Now, the other thing we're starting to see is we're seeing a lot of soldiers come back from war with bipolar and traumatic brain injury. We're seeing a lot of these IED blasts and things that are damaging soldiers' brains. They're causing bipolar. And that's where a lot of research, the government has actually put over $50 million into funding research on soldiers for bipolar at this moment. So I think that will bring about a lot of findings. So we have to stay tuned for that. Now, some other things, brain structure-wise, we do see some differences. There's two. The basal ganglia and the cerebellum are smaller. So if we were to, I couldn't, pull our brains out and put them on the table. And if you put somebody with bipolar's brain and, my brain doesn't have bipolar beside each other, we wouldn't be able to say, oh, look, that's smaller. But if, we're looking at it in a microscope, there are very minute differences. The basal ganglia is involved in reward and pleasure. So, and I think about it with little kids, if you have a little kid and maybe they're acting out, hitting their brother or their sister, and you put them in a corner, or you spank them or whatever, then they're usually not going to do it again, hopefully, or at least they'll hesitate next time, right? Well, we know that the basal ganglia is responsible for a lot of that. That's where that's the ability to learn from rewards and punishments. That's a part of the brain. It is smaller than someone with bipolar. And the cerebellum is kind of a bigger part of the brain that houses that. And then we have lower gray matter. Gray matter, for those of us who've seen a picture of the brain, you know the really wrinkly, it's like really wrinkly. And the brain, actually, that really wrinkly part is what we consider, that's the cortex that goes underneath the interior of the brain, which is kind of the basic primitive brain. And that basic primitive brain is where the gray matter is. And gray matter is basically just the meat of our brain on the inside. And we know that people with bipolar have significantly less of that gray matter. And then we have all of these different areas that are also abnormal, meaning that sometimes they're bigger, sometimes they're smaller, sometimes they're the same size, but there's definitely abnormalities in these areas of the brain. And some that are kind of important, the amygdala, I talk a lot about. It is the emotion center of our brain. Every emotion we have goes through our amygdala, which is right here, in the middle of our forehead, straight back. And then the hippocampus is memory. That is the memory center of our brain, where all of our memories are stored. And these are all abnormal. And then prefrontal cortex, which is all of this here, which is our impulse control. And we know that they are abnormal. Now, I would love to be able to tell you why they're abnormal, but science is not advanced to that point. We do not know why they're abnormal. We just know that they are. And then, when I talk about these disorders at Mesa, when I do these presentations, I always talk about cultural factors, so relationship factors and things like that. But, bipolar is one that really is considered more of a biological disorder. Really, in the field, they consider it a strongly biological disorder that will be cured biologically. That there is no, I had a bad mother syndrome for bipolar. It's something, and we've gone over the brain differences. It's something that we see very real physical differences in. All right, treatment. So now we get into treatment, and the first one I wanted to talk about is, the major therapeutic goal is complete remission of all symptoms. And preventing the future episodes, so preventing those periods of time where you have manic symptoms or depressive symptoms. Now, we know through lots of research that a combination of mood stabilizing medicines and therapy is the best treatment. So even though this is considered mainly a biological disorder, we know that support groups, we know that things like educational events help and can help. Now, the main drug, and it's still the first one and the most effective drug medication that has ever been for bipolar is lithium. Now, those of you who know your table of elements also know that lithium is on our table of elements. It's a basic element. And it has been used, and we know that it's 60 to 80% of people who take it have a decline in manic episodes, a serious decline. And it's pretty effective. And if you were to look at penicillin, rates of penicillin effectiveness and everything else, every other pill that we take, this is one of the top ones. 60 to 80% is extremely effective. We know that people who take lithium, there's a decreased risk of suicide. And then we also know that there are some serious side effects. And, as I said, it's on the table of elements. And I think when you put something in like that in your body, there are going to be some side effects. And nausea, weakness, restlessness, all come along, usually come along with it. So we see a lack of compliance, and it's hard for people to take these medications because of the side effects. Also, some of you might know that when you first get on these, it takes a little bit of a trial period. The doctor has to do very frequent blood tests, urine tests, because there is a very small window of how much you should take that will be beneficial to your bipolar versus the side effects outweighing that. So that is a very important process of taking lithium and spending, sometimes it takes months to figure out what dosage is going to be correct for you. Then, since, lithium has such a bad non-compliance rate because the side effects are bad, what we see the most common step, and then, working with doctors here in Grand Junction, this is what doctors in Grand Junction do in Colorado and everywhere I've been. Usually the first thing they will do is they will prescribe an atypical antipsychotic, which is they're a class of drugs that have been shown to help with bipolar 2. And these are the 7 most common antipsychotics that are prescribed in the United States. And a lot of us might recognize some of these names. Risperdal, Zyprexa, I know that those are very popular here in Grand Junction. A lot of doctors use them. So, and what these drugs do is they work on a neurotransmitter we haven't talked about yet, which is dopamine. So as I said, the way our brain communicates is we have that electrical impulse inside of a neuron. And once that happens, it signals that neuron to release a neurotransmitter, and that neurotransmitter floats across that space, and it goes to the next neuron, and the next neuron absorbs that chemical, and then it passes the message on. And if anything disrupts in that, then we have a problem, right? So what these drugs do is they actually go in and they attach to the neurons, and they attach to the places on the neurons where they absorb the neurotransmitters. Now, on our neurons, we have different places, I call them docking stations, because I think of little spaceships flying across and kind of dock. And then they send a message and it goes on. Well, those docking stations, or those places where it's absorbed, we have found a way to block those, and these medicines do that. So when you take Risperdal, what happens is Risperdal, you start taking it in your brain, that medication will block the receptor sites, or the docking station, where dopamine is absorbed. It literally clogs it up, shuts it off, so that the messages that are received and sent through dopamine cannot be received or sent anymore. Makes sense? So it's blocked. And while you're on that medicine, it is completely blocked, and dopamine will not be transmitted through there because those receptor sites are blocked. Which, what it does is our brain figures that out after a while, right? I mean, it was been the doctor say, well, it's going to take a couple weeks, a couple days for your medicine to start working. Well, what happens is our body and our brain eventually catches on, and we stop releasing so much dopamine. And dopamine, we get a lower level of dopamine. Does that make sense? Because we block those up, brain catches on, and it leads to a lower level of dopamine in our brain. And we know that symptoms of bipolar go down once we do that. Now, these medications, as we can see, these are atypical antipsychotics, and these actually were developed for schizophrenia, not bipolar. They do lower the symptoms and they do work, but they don't work as well as lithium. Now, so why do doctors try them first? Because the side effects are not as severe, is why doctors try them first. So a doctor will try these first, hoping that these will work, and you will not have to go on with them. But they do work around 50% from what I've seen. All right, we're almost here. And you can see sometimes doctors will also try combinations of antipsychotic and anti-seizures. I know there's several doctors here in town that try Depakote and Seroquel. Depakote is an anti-seizure medicine that was originally given to kids with epilepsy, and it has been shown to help with bipolar, and then Seroquel is one of those antipsychotics. And then antidepressants are sometimes given by doctors too, when the depression is bad, but we know that those medicines, they can actually make the mania worse. Antidepressants can actually make somebody have a manic episode, so doctors should keep really close monitor on people when they put them on there. Now, most people respond to some medication combination, but there is a population of people with bipolar, 10 to 20%, that do not respond to any medication. Right, and then we have our psychotherapy, and most of it is focused on family-focused psychoeducation. So it's not only educating the client on what bipolar is, how to manage the illness, but the family and getting social support for that. And then we have our interpersonal therapy, which interpersonal therapy is a therapy that focuses exclusively on your relationships in your life. So we know that people with bipolar, if you have strong relationships in your life, it's actually related with less manic episodes, less of those rough times. And social rhythm therapy, which is probably the most popular that I see, which is the creation of the day-to-day routine. It's really planning out life, really planning out everything so that you avoid disruption of your circadian rhythms. And we've talked about how bipolar seems to be related to the genes that involve sleep. We know that, if somebody misses a couple days of sleep who are bipolar, their chances of having a manic episode go way up. So if we can get them into, a very organized day, a very organized life, that seems to help. And also, if we chart mood, so in social rhythm therapy, you will chart your mood day by day. What you start to see over time is that you will be able to predict when you're going to have a manic or when you're going to have a depressive episode within 1 or 2 weeks before it actually happens. And that's big, right? Because then we can plan ahead. Then we can notify family members. We can make plans ahead. We can make plans at work. We can do all of these different things to manage it ahead of time. And we do know in general that 60% of people improve with treatment. So, it's pretty good. The majority of people are improving with treatment for bipolar. Now, this one's exciting. Neurofeedback. Has any of us heard of neurofeedback in here? Neurofeedback is the newest method of therapy, of treatment that's coming out to treat mental disorders. There is really strong scientific evidence that this works for ADHD and other disorders like that. But what neurofeedback is it's kind of weird. A lot of people think it's weird when they first see it, but neurofeedback is when it's like an EEG machine. It's basically what it is. It's an EEG machine, and you would sit down, and they would hook you up to electrodes on your brain, and on the computer screen in front of you, you would see your brain patterns, your EEG waves of your brain. And your brain puts out, we have that electricity in there, so it puts out different waves and signals. And neurofeedback, what it is it's a machine where they would hook you up, monitor you, and see your patterns, and they would compare that to patterns that we know are in mentally healthy individuals. Then you would do a series of treatments where they show you different images on a computer screen and make you do certain tasks with your brain that change the EEG waves in your brain over time after practice. So you're basically training your brain to put off different EEG waves and to function in a different way. Now, this is all related to circadian rhythm, right? We're talking EEG and circadian rhythm, pretty much basically the same thing. So we know that it works for ADHD, it works for some other things, and they're just now doing studies on it with bipolar. And this was 40 patients from the University of North Carolina, and this was just last week when this was published. So they take these people in, hook them up to neurofeedback, and literally you go in once a week for 30 minutes, stare at the computer screen, do the little tasks. You do it. This was after 12 weeks of the results. And there was 40 patients. 36 out of 40 of them were able to reduce the amount of medication they were taking. 5 of them were able to stop medication completely. They reported better independence, better ability to control themselves, improved relationships, better performance at work, a dramatic reduction in hospitalizations. And then the patients who remained on medication said that that flat feeling that you get from medication sometimes, that went away also with this neurofeedback. So I can't say anything for sure that this definitely works for bipolar, but the initial findings are great. Now, maybe some of you are thinking, wow, this is awesome, but we're in Junction. Where are we going to get access to a neurofeedback machine? The great news is that we have one here in town that is right here at Behavioral Clinical Services. Now, I will tell you that that's also who I do my private practice to, but I'm not trying to promote their services, but I kind of am. And, they have neurofeedback there. So one place in town that I know of that actually has it, and they have a certified administrator of neurofeedback there. His name's Steve Robinson. They also do a sliding fee scale, which is a big thing, meaning that they base how much neurofeedback costs on your income. You won't be paying more than what you can pay, is basically what that means. So that is a great place and kind of a great new finding that Minnie's might want to look at. Now, prognosis. We know that on average people are symptom-free for about 5 years between first and second episode. So, not too bad, right? We're looking at 5 years in between being sick. We put episodes of mood swings get closer together as we age, but they're not as severe. You know that. And then, on average, somebody with bipolar has 8 to 9 mood episodes over a lifetime. So, I think a lot of people are shocked by it, not quite as frequent as we would think, with 8 to 9 over a lifetime. And then the majority of people are able to manage it without treatment. And then the last thing I have about bipolar, these are 2 great books. You know, I told you about the neurofeedback, but these are 2 books that I think are must reads. One or the other. I mean, you don't have to read both, but these are really good self-help resources that you can get in any bookstore or on the internet that are up to date, give you all the information you need to know on how to manage bipolar or help somebody in your family who's trying to manage bipolar. Okay. I think we're going to turn it over here.
All right, so now we're going to have Crystal Kitzman. She's going to come up and she's going to share her story with us.
I wish I had this. This is really cool. I'm Crystal Kitzman. I just want to give you guys a little information about myself. I am a stay-at-home mom. I was originally a student over at Scandia. I was going to art education. I've been married for many years, and then we planning in January. I have a toddler boy. His name is Elam, and he's 2.5, and he has autism. I've been advocating with him for the past 6 to 7 months. Now, I do want to let you guys know, I do have bipolar. It is bipolar 2. We've been going back and forth whether or not I have cyclothymia or bipolar, because for me, I do not have full manic episodes. But, you know, I just would like to let you guys know that a part of me knowing that I had bipolar was a part of this whole journey, and not all of it is pretty. I was diagnosed about 2 years ago, shortly after my son was born. I was suffering from postpartum depression really badly, and we were just going through a really rough time. My best friend completed suicide. My mother had passed away 3 months after. We were one of the many foreclosures in the valley, and it was mostly attributed to a complicated pregnancy I had with my son. We had filed for bankruptcy because we couldn't hold up on our bills, because I actually had lost my job after I had my son. And then we had our vehicles repossessed. So it was a lot. It was a lot to handle. And so, you know, I did, in my mind, what I thought most people do was I went over to my neighbor's house and I had a couple of drinks. And I thought, you know, this is just, you know, shooting the breeze. I'm going to finally let loose. And it was the worst thing that I could have done because I was self-medicating. And my depressive episode hit really badly. I attempted suicide that evening and was admitted to Colorado West for 3 days of observation. Now, just a little bit further background information. I've always known that there wasn't, I knew that I had some sort of a disorder growing up, but it wasn't a, you know, I'm trying to like pick and prod or, But when I was about 19, 20, I started to notice that when I was in college, I was either the life of the party, and I was just super social and really happy and always a positive image. And then when, a few months later, I would have just these terrible depressive episodes where I just couldn't even get out of bed. And, in my mind, I just thought, I didn't mean to stereotype, but I thought I was a woman and I was moving. I moved from Boulder and I was going through separation anxiety from the life I had lived. So I continually justified it. So I didn't seek any help or any treatment. Now going back to that, when I had been diagnosed, it was probably 7 months after I had been admitted from Colorado West. This is because we had to go through a variety of different therapies. And with the therapies, just like Jake was saying, there's really no magic pill. I had to go through a variety of different things. I have tried lithium and it was very effective for me. But the side effects that I've endured from all of the medications that I've taken are very expansive. I've had weight gain, I've had sleepiness, I've had staying awake all the time, I've had migraines and headaches, I've had muscle aches, I've had physical tremors, both facial and fine motor. And then I've also, one of the most unusual ones was I actually got carpal tunnel from one of my medications. It's really rare side effect, but I was apparently really susceptible. So, but what I have tried over the course of the past couple of years is I've tried natural supplements. I've done B12, GABA, multivitamins, omega fish oils. I've done antidepressants, which that was how they were able to determine that I had bipolar, because when I took the antidepressant, I went straight into being like what Jake was saying, because it just was, it was almost immediate. I took it and then the next week I was just, so, but then I have taken anti-anxiety. I've taken mood stabilizers, which was the lithium. But then I've also done non-medication, which is like biofeedback. Now he had spoken about neurofeedback, but biofeedback is also very effective in treating bipolar. And it's where they actually hook you up, they monitor your heart rate and your breathing rate. They have a glycerin or so. And they give you this image, and they have you focus on the image. And while you're focusing on it, you have to monitor your breathing. And it helps reduce your anxiety. So then they actually can figure out what your optimal breathing rate is that can actually lower your, sorry, I'm having a brain fart. that can lower your stress, essentially. So that really, really helped me out, because when I have anxiety, which is also very common with bipolar, it almost feels like I can't get out of it, and it's one way that I can control it to prevent it from getting any worse. Now, one of the things I'll say is that with the medication and with the treatment, it isn't linear. There were things obviously that didn't work and things that really did work. And the thing about it is that I still have that possibility that I could fall off of recovery, but I have family and friends behind me that are aware, that have been educated, actually through Nami. They took the family-to-family course. My father-in-law, my father-in-law, my aunt, uncle, sister-in-law, husband have all taken the course, and actually 2 of them are a part of my action plan, which is one of the things that's really important for anybody that has any kind of mental illness. It's good to have those 2 people that you can say, that you can just say, I'm not feeling right. Can you keep an eye on me? Make sure I'm going to be okay. So, alongside with the treatment, I have a lot of different coping skills. We all have our hobbies. I'm an artist, so I love to do painting and drawing, and I like to write poetry, and I listen to music. Often I will cuddle with my son if he'll let me. I like to exercise 2 to 3 days a week, which actually do that, I can actually track it, and it helps me kind of be able to see on a physical level where I am going to hit a manic episode, and that's like what Jake was saying, that when you can take a look at that, you can anticipate those swings. So, but I do have to say that, you know, through everything, it's hard to believe it's been 2 years since this has all happened, but, you know, I have a lot of successful stories out of it. The fact that I'm here, and that I'm able to tell you guys that I have bipolar, you know, and that's the thing. I'm me. I'm not bipolar. I have bipolar, and that's one of the things that I think people often misconstrue, and I don't think it's intentional, but, you know, it's, somebody has diabetes, somebody has congenital heart failure, or heart problems. They are not what they have. I'm not bipolar, I have it. And that's what we really need to start to embrace, because that's where the stigma is arising, and how we need to nip it in the bud. But I have a lot of things that I've been able to do since I've been diagnosed. I advocate for my son. I actually am starting a support group for families that have children that are on the spectrum. I am advocating with Strive to start helping with them on that. I actually am hoping to work with Nami and do a art gallery with them, which will be very exciting. But the biggest thing was the fact that when I was where I was happy that I can look that I came from there, and that I'm able to be a mom, and I can support my husband and my family, but knowing that I have to take care of myself first to be able to take care of them. And once I was able to recognize that, everything started to really pan out. I really, really did. Sorry, guys. I really enjoy advocating for them. They've been a godsend. They've been amazing. And if you guys have any questions, I mean, ask them, because family to family's been amazing. I do IOOB. Erin Sheley over here also does IOOB, and would be more than happy to contribute to anything else that's going on in the valley. So, and I'll be happy to answer any further questions.
Thank you, Dr. Jones, as well as Crystal, for sharing about bipolar and sort of that brain part of it and body part of it, and also just the personal testimony of it. Let's just take 5 minutes. We'll just sort of take a break. The restrooms are just right out here to your left. If you want to grab something to drink and a cookie, we'll just take 5 minutes, and then we'll get set up for our next question.
Hey there, how you doing there? Very good. Good.
Take care.
I'm sorry. Good.
Hey,
Hey,
how are you?
good. How you doing? Hanging in there, huh?
Yeah.
Good.
I've been catching myself yawning.
All right, so now I think we're going to transition to talking about schizophrenia. And I'm going to try to not be as long-winded. You know, I'm a professor who has the summer off, so evidently to say than what I thought. But and you know, I'm very passionate about this. I can talk about this stuff all day, and I kind of do talk about this stuff all day. Amazingly painful. So, but now we're going to get into schizophrenia, and schizophrenia and bipolar are actually very, very related. So if we were to look biologically and bipolar, they are really, really similar. And a lot of psychologists have actually argued the fact that they think that bipolar is actually just another form of schizophrenia. And that has been debated in our field for about the last 10 years now. That debate has, gone the way of separating those two. But it has been debated because they are very similar biologically. We'll see some of those similarities. So, and once again, I want to talk about some of the symptoms of schizophrenia. Schizophrenia is what would characterize, psychosis. A lot of us have probably heard this term. Freud originally came up with that term. It's what he called all mental illness with psychosis, which is, a condition involving a loss of contact with or a distorted view of reality. So it's not seeing the world through the same lens that other people see the world. And you can see, impaired cognitive processes, personality change, mood changes, and social withdrawal are all part of schizophrenia. We know that lifetime prevalence is about 1% of the U.S. population, so it's not a really, really common disorder, but we do know. And you can see the cost, healthcare cost, is $62.7 billion annually for this country. And that's from Obamacare. Now, in the past, we've described schizophrenia as, there's been like 5 different types of schizophrenia: paranoid schizophrenia, disorganized schizophrenia, catatonic schizophrenia. But really, the field has moved away from that and describing it this way. And the majority of doctors you'll see today don't really describe it that way. Because the reason is because it doesn't really hold up. People don't really fit into those nice little categories like we thought they did in the 80s. Now they really describe schizophrenia as you have type 1 schizophrenia and type 2 schizophrenia. Type 1 schizophrenia would be you have more of the positive symptoms than the negative symptoms. And we'll talk about what the positive symptoms are and the negative symptoms. And type 2 is more of the negative symptoms. Now, people still don't really fit neatly into these categories because most people really show both types of symptoms, but usually the majority of people will show more positive symptoms than negative or more negative than positive. So we can loosely put them into those categories, which helps treatment. Now, what the positive symptoms are the stuff that we see glamorized a lot on TV and Hollywood and our media, are the things like hallucinations. Hallucinations are when you have a sensory perception, so that doesn't exist in the environment. So one could be vision, is that you're seeing things, maybe shadows or glimmers of light that nobody else sees in the room, or you're hearing voices that nobody else hears. And then delusions are false personal beliefs that are firmly held. So this could be like, I could adamantly deny that I am not in the health department right now. I am not in this room. And then no matter what you all did to prove that to me, I would still not believe that. That is a delusion. And then disorganized thought and speech. This is, more of that difficulty focusing, shifting from topic to topic, so it's difficult holding a conversation, communicating with anyone. And then we see abnormal motor behaviors. Now, we actually see these a lot more in Asian cultures. We see that in Asian cultures, they mainly present with the abnormal motor behaviors, and these are less. But in the United States and in Europe, we see that these are much more prevalent than these. But we do see the abnormal motor behaviors, which is peculiar body movements, posturing, which is holding a position, so maybe standing in this position for 7-8 hours, and maybe even longer sometimes for more severe patients. So those are the positive symptoms. And the negative symptoms are 4 A's, as I like to say: abolition, algeia, asociality, and restricted affect. So it's a lack of goal-directed activity, so a lack of meaningful speech, lack of interest in social relationships, and little or no emotion. And those are the 4 main categories of negative symptoms that people with schizophrenia show. And you can see that 15 to 20% of people with schizophrenia are type 2, which would be those who display primarily negative. And then we're looking at, 80 to 85% of people are type 1 schizophrenia. All right, the course. This is I got nice little graphs for you. This one. These are the different courses. So this is how it plays out over a lifetime. And And you can see we got percentages for each course. And we can start with the most common one. And we see that 33%, so about 1 out of every 3 people with schizophrenia follow this course. And this is they have a psychotic episode where maybe they're hearing voices, maybe they have some delusions, and then that will, slowly go away with treatment over time, and then we'll come back close to where they were before as far as function. And then maybe they have another episode, and you can see that in between each episode, it progressively gets worse. They do not recover completely, and they recover less and less after each episode. And that's about 1/3. And then if we go about 17%, we see that they have an episode, and they go right back to functioning almost normally. And that will continue throughout their period of their life. And then we go 14.6, which is you have an episode and you go back to completely where you were before you had the episode. And then we see 12% is you just have one episode. So we do have about 1 out of 10 people with schizophrenia, they only have one psychotic episode, and that's it. You never have another. And then course 5, which is the least favorable, I guess, is that you have a psychotic episode and they never really come out of that psychotic episode completely. And this is usually the people we see that need extended care, need to be in a hospital, or they need to have some type of home health care through that. And then the etiology, we actually know quite a bit about schizophrenia, because schizophrenia, schizophrenia, I say, kind of started at everything. This was the first disorder that Freud recognized was schizophrenia, because I think it is so dramatic. We can see this disorder. It's kind of obvious a lot of times if somebody is severely schizophrenic. So we have quite a lot of research on different areas. And when I talk about the etiology of any disorder, as I said in the last one, there's 4 different categories to talk about. Biological is one, so what's going on in the body. Psychological, so we're talking about thoughts, things like that. Social, we're talking about relationships. And then cultural, socio-cultural, we're talking about cultural influences, and there are several cultural influences. And it's believed that in the field today, this is the most popular model of understanding mental disorders, that all 4 of these dimensions combine to create schizophrenia. So we're kind of expanding. Okay. Now, we do know that 20 different genes have been identified for schizophrenia. It's very heritable. We are up to 20 now, so you can see that the research on schizophrenia is more advanced than it is on bipolar. And now they've really stopped identifying these genes to try and figure out why these abnormalities are occurring. And the biggest pattern that we see is that we know that the genes associated with these 4, and you can see memory is here, but these 4 parts of our brain, those are very related to schizophrenia. So when we talk about executive functions like impulse control, planning, things like that, and then sustained attention and memory, we know that those genes that are passed down through families are very related to schizophrenia and they're being passed through families. And then we have a nice little, this is risk factors. So we can see here monozygotic twins, so that's our identical twins. If you're an identical twin and we do the whole thing where they're separated at birth, we can see this is the percent chance that you would have in having the disorder. And we can see identical twins, we're looking at almost 50% chance if your identical twin has it, you will have it. And then if both of your parents have schizophrenia, then we're probably around 46% there. And you can see it goes down as we look at different levels of sharing gene. Siblings, we're looking at 9%, whereas in the regular population, 1%. So we're looking at 9 times greater if you have a brother or sister with these. All right, so we see some real strong brain differences. One of the big brain differences is gray matter walls. And I talked about the gray matter, and here's our brain, and this is that wrinkly stuff I was talking about. And we see this in bipolar too, like we talked about, but it's much more evident in schizophrenia. And you can see that these different colors represent the percent change over 1 year. So you see the blue here, and we can look at a normal adolescent boy here, and you can see that this part of the brain is in blues, which means he lost about 1%. We're all losing brain matter, gray matter as we age, our brain deteriorates as we get older. But you can see a normal adolescent boy about 1% in a year. Now, if we look at an adolescent boy with schizophrenia, you can see it's in the red, which means that they're losing about 3% of their brain matter every year, compared to 1% with an older. And we see the same thing, you know, the interesting thing, it is a little different in girls. You can see there's a little different pattern when you compare girls. But, you know, we're talking about, you know, double, triple the amount of gray matter loss over a year for somebody with schizophrenia. They do not know why this happens. They have not figured out exactly why this is going on. There is a theory we'll talk about, but when we treat based on that theory, it doesn't stop this. So my thoughts, well, it's not a theory anymore because we proved it wrong. But they don't know why this happens. So, and the theory is the dopamine hypothesis, and a lot of us might have heard of this. So a reason, one of the very first and still one of the strongest explanations we have for schizophrenia is that there's too much dopamine in the brain, which is the neurotransmitter that helps us communicate. And we know that. The majority of people with schizophrenia do have too much dopamine in their brain. That is proven. Now, it's not proven that it causes the gray matter loss, which is kind of the bigger picture here when we talk about schizophrenia. So we know that there's too much dopamine, and they kind of found this out by accident, to be honest. The way they found this out is L-DOPA, and some of us might have heard of the drug L-DOPA. L-DOPA is given to Parkinson's patients because Parkinson's is the exact opposite of schizophrenia, which a lot of people don't know. Parkinson's is not enough dopamine, which leads to shaking and all of our Parkinson's symptoms. So what they did was they developed a drug for Parkinson's called L-DOPA, which is a synthetic form of dopamine. It mimics dopamine. We take it and it mimics dopamine in our brain. And what they found is that if they gave too much L-DOPA to Parkinson's symptoms, to Parkinson patients, they started displaying symptoms of schizophrenia. So some doctors somewhere said, whoa, maybe we could do the opposite and that would start working. And that is when they developed the antipsychotics we talked about with bipolar, and one of those is Thorazine. And as I explained, it blocks those dopamine receptor sites and lowers the amount of dopamine in your brain. And that's the main treatment for schizophrenia. We use those antipsychotics. It's the best treatment we have, is lowering the amount of dopamine in the brain. And, you know, it's widely used. Some psychological things. So some things in our environment that we know. And you can see that I highlighted cannabis in this because, you know, it's legal now in Colorado. One thing that we definitely know is that cannabis use 6 times is the last study I saw. If you use cannabis regularly as a teenager into adulthood, your chances of having schizophrenia go up 6 times. Because a lot of people don't realize that marijuana is a hallucinogen. It has a hallucinogenic effect in our body. So we see things like cocaine, amphetamines. I didn't put LSD up there, but things like LSD increase your chances of having schizophrenia. And then here are some other factors in our environment we know that increase the chances of schizophrenia. So for children, if we look at, you know, maybe they're in a traumatic accident, you know, it goes up about 1.5 times their chances of having schizophrenia. And then we get into bullying, which we're hearing a lot about in the news, maltreatment. But really, if you combine bullying and then maltreatment means maltreatment by the parents or their guardians in the home, so abuse or something like that, then we see that it increases the chances of schizophrenia by almost 6%, which is pretty dramatic. So we know that we're not saying that these things cause schizophrenia, but we do know that they can definitely contribute to the development of schizophrenia. And then expressed emotion. This is, I think, is a really important piece. Expressed emotion is a negative communication pattern in the family. And the way I describe it is it's when a family communicates in an overly critical, hostile, and maybe there's a little too much emotional involvement with the family members. And we find this in the majority of schizophrenic patients' families, of this pattern of criticism and hostility. Now, there's a couple of different theories. Some people say, well, and Freud, if you remember, this is the disorder that Freud became famous for saying it's all mom's fault, right? Well, nobody believes that anymore because it's not mom's fault. But this is kind of where it came from, is that we started looking at the family. And that some people say that, this calls it, there's really three different ideas here. Is that if there's a lot of criticism, a lot of hostility, a lot of over-involvement in the family, then that can lead to relapse for that person who is schizophrenic. Another idea is that the patient has these hallucinations, these delusions. It puts stress on the family, and that leads to a hostile environment, and it also leads to relapse or a psychotic episode for that person. And then the model that I like the best, that I think I approach through my personal experience, is that the patient has these symptoms that are difficult to deal with. It causes expressed emotion in the family. The expressed emotion also causes more of the odd behaviors. And then all of that kind of combines. So the blame goes to everyone. And that leads to relapse. So what we have found is that if we can do things like family-to-family support groups, and we can educate families on how to understand and deal with somebody with schizophrenia, what we would call odd behaviors, is that it prevents relapse, and people with schizophrenia have less psychotic episodes, they report feeling happier. So, and now it came from kind of, who would have known? Freud blamed it on his mother, actually blamed it on his mom, led to something good, right? Okay. Now, culturally, we do have some differences. We know that men actually get schizophrenia earlier than women. Once you hit the mid-40s to 50s, more women than men are diagnosed. And one of the beliefs, and where research is going, is that they believe it's because of estrogen. Estrogen has been shown to be a protective factor in diseases like MS, Parkinson's, a lot of our neurocognitive diseases, and it's also been shown to be a protective factor in schizophrenia. We know that women's estrogen levels start to decrease in the mid-40s and as they get into the 50s, and we see the rates of schizophrenia going way up for women. And then, yes. Right, and the antipsychotic, we talked about these with bipolar. It's the same class of medicines. It's the exact same medicines that they're using. They do the same thing. And we know that it does reduce the positive symptoms, but it does not treat the negative symptoms like the social withdrawal, lack of goal-oriented behavior. That is not something we have medication to treat. But they can manage those positive symptoms pretty well. Okay, and then psychosocial therapy. There's three types of therapy: inpatient, cognitive behavioral, and interventions based on family communication, which we'll talk about. Now, the most successful that I've seen, and a little personal tidbit about me is my aunt has schizophrenia. And when I was young, we spent, my aunt had a psychotic episode, and she had, a husband and kids, and then kind of everything fell apart, like it unfortunately does for a lot of people. And she moved in with us when I was young. But my mom was trying to take care of her sister, take care of two kids, a husband, and trying to work full time, and it just wasn't working. So I spent a lot of time, and that's really when I got my first interest in psychology, because I spent a lot of time with my mother as an 11-year-old looking for treatments for my mom. And what we found was Malou therapy, and it was really the best thing I think we could have ever found for her. Malou therapy is a hospital as a community. And where my aunt is still today, she's been there for 25 years and has done great and is the happiest she can be, it's basically, the way I describe it, it's an apartment building for people with schizophrenia. And she's there and she lives with almost 100 other people who have schizophrenia. They have staff there, nurses, doctors that manage their medications, that help them. But what it does is it does psychosocial skills training. So what she does is she goes into doctors' offices after hours and cleans them every week. She does it 3 times a week, and they pay her salary. Give her transportation to and from there. So mood therapy really is the community of people who come together and they live together, and they get, there is assistance from medical staff. They live together, and we found that this is one of the best treatments for addiction. And she, like I said, she really enjoys it, and it's really worked. All right. And then we also have, that would be considered inpatient treatment, and then we have cognitive behavioral therapy. And there are steps that are pretty clearly outlined for this. And these are the steps, things like engagement. A lot of this comes down to awareness. And I think Aaron will probably talk a little bit about this. But one of the big steps in treating schizophrenia through therapy is separating real from not real. And then after you do that, then understanding and coming to grips with what is unreal and how to deal with it. So for example, you're hearing voices, separating what voices are you're just hearing versus what somebody is really saying to you in your environment. So it is really a lot of insight building, a lot of acceptance, normalizing it, saying yes, you can live a normal life with these symptoms, and people do. And then moving forward from there. And very simple explanation. Then a lot of family communication and education. You'll notice Nami does a lot of this. This is a big part of that piece of getting support for others. I read one of my favorite research studies I ever read in grad school. In just getting my doctorate, they make you read like thousands and thousands of these boring research studies where they talk about what scale they used for 2 pages. They're reading about the intricacies of a self-report questionnaire, bore you to death. And one of the studies I read was, it was a very simple study done out of Utah, and it basically looked at people who were schizophrenia, who had 2 or more people that they felt loved in their life, versus people who had schizophrenia that did not have 2 or more people they felt like loved them in their life. And what they found is that the people who had 2 or more people that loved them in their life were drastically, had less hospital stays, had less psychotic episodes than the people who did not have that. So family support, love, all of that is great. So, and my aunt, the one who's in the mood therapy home, she's had the same boyfriend for 10, 15 years now. And I'm telling you, before boyfriend versus after boyfriend. We see that. So this is in a very part, one of the most serious and one of the most biologically, we see more biological changes in the brain for schizophrenia than just about any disorder. And I always think it's interesting, though, that something as simple as love can make such a huge impact on a disorder. All right, and long-term outcomes. So what are we seeing in long-term outcomes? We know in a 10-year study, we saw that the majority of people with schizophrenia improved over time. In a 15-year study, they showed that 40% showed periods of improvement. So what does this tell us? Kind of contradictory, right? Schizophrenia is definitely one that's case by case. It varies drastically. So we really have to kind of take it case by case basis. And then lastly, I found this statistic I thought was interesting. And where are people with schizophrenia living? We see that the vast majority are either living with a family member or living on their own. We get 59% living with a family member or living on their own. And then, we see down here 5% hospital, 5% homeless. Now, if I would have put this statistic up there in the 70s or the 60s, we could have flipped this. We could have gone homeless, 34, hospitals, 25. It would have been completely opposite. So we have made some great strides in treating this. All right, and then here are I like to give my 2 favorite, I think, self-help books for schizophrenia, and that topic is great. This one I sat down with my whole family and went through it when I was about 16. They're on the 4th edition of this, I think, and the 5th edition comes out in December of this year. So I think the one that I went through is like the 2nd edition. But it's a great book and drastically helped my family. All right, I'll turn it over.
Sheley is going to come share his story, and afterwards we'll have time for question and answers.
Hi everybody, I'm Aaron Sheley. Just want to start out by saying that I'm really into writing, especially stream of consciousness writing and the other art forms that are related to that. I learned how to make films at the University of Southern California. Glad to be here. And mental illness is a topic of great concern to me. Let me just start off by telling you the beginning is always the worst, because what happened was I was attending graduate school at California Institute of the Arts, and my stress and lack of sleep and drug use became full-blown insomnia. The insomnia led to hallucinations, visual and oral, mostly visual. The hallucinations are dreamlike in nature, like you're dreaming when you're awake. And then I was diagnosed with schizophrenia, a mental illness of the mind. I was unsure about the medication that they were trying to give me, which led to many hospitalizations. In the process, I went through a divorce, and the worst symptoms were disorientation and delusions, which continued for years. So the way I came about acceptance is I struggled with it for about 10 years, but the last few times I was hospitalized really opened my eyes to the difference between reality and non-reality, as Jake was talking about, which my disorder in its full-fledged phases distorts extremely. When making film and writing, I've had success in the past, and sometimes it's led me to thinking that I didn't have an illness, or the intensity of the project itself just increased the illness. So I've been convinced in the past I was fine and quit medication, and when I quit the meds, I went back into a state of non-reality. But now I have an acceptance, that I incorporate into my work even. So the way I came about this, though, was from the treatment. And the treatment, I'm one of the lucky ones that as long as I'm compliant and regularly taking medication, I'm a very highly functional person. It's that non-compliance when it didn't work out for me. So medication is a huge part of my treatment plan. I take meds to sleep, meds to stabilize my anxiety during the day. I'm also given an injection once a month that relieves stress. Therapy has a huge impact on my healing process. Once a month I see the therapist, once every 3 months, and she gives me useful techniques to disengage from distracting thoughts. By meditating, the counselor explains that thoughts are just thoughts and intent is everything, and thus I can just dismiss unwanted thoughts, which is really key to therapy. As far as coping skills go, the healing process began for me when I made a list of good qualities versus bad qualities, and the good outweighed the bad just barely, Writing is a nice therapy, and I also direct art films. Watching movies, reading, and furthering my education helps deflect unwanted thoughts. I find that by watching old classified masterpieces, it focuses my attention on something other than distractions. And prayer is also very therapeutic. So my biggest success is being highly functional and able to talk to you right now, because I was in bad shape, Focusing on my personal achievements is quite therapeutic. I've had success with writing. My stream of conscious blog is very popular online. I'm making videos for my church and for Nami. I've made about 7 movies, 2 shorts, 4 features, and a featurette. A few of them are on YouTube. You should go check them out. The short went on to worldwide success at film festivals. It was produced by Aspen. And I've also published in an LA magazine called Entertainment Today, some of which is on the internet. So I'll leave you with this thought. It's not easy to go through a mental illness. It's never easy, but you know, you can come out the other side and still live your dream. And I just think everyone should know that. So.
So we'll just have Crystal and Aaron and Dr. Jones, they can just grab a chair and then we'll let you ask questions. Yeah, and we'll try to get the trust Battery's not been my friend today. So. There we go. Feel free to ask questions.
Are they going back to the atypical antipsychotics at all because of the side effects of going back to the typical antipsychotics because of the side effects of the atypical antipsychotics of weight gain and?
Yeah, that's an interesting point. And, there's two classes of antipsychotic medication. There's the first round, I would say the first round of medications that came out, probably I think 70s, 80s, maybe the early 70s, that came out that were being used. And then recent atypicals is what they call them, came out, newer antipsychotics that, a lot of you've probably seen the, commercials of like the glowing butterfly saying that take this pill and your life will be wonderful type of stuff. But they were really promoted as having less side effects, being so much better. And what they have found in the last couple of years is that all of that is kind of not true. And that they are effective and they have different side effects, but not less side effects. So I think that's where we're hearing a lot of that from now, is that now people are saying, oh, these drugs aren't, no side effects and aren't all this stuff that they were promised to be by the drug companies. So now doctors, I think it's really 50-50 of which side effects can be managed better by the patient. So kind of pick your side effects, I guess, because both are about the same amount of effectiveness. Does that answer your question?
Yeah, thank you. So they are starting to look at them again.
They are. They're starting to prescribe more of them again, more and more.
Have you heard of any new drugs coming down the pipe?
Not antipsychotic wise. Merck is saying that they're going to have a new pill that combines the anti-seizure and the antipsychotic. Because remember I was talking about bipolar. Sometimes that's an option for people with bipolar. So they would take Depakote, which is an anti-seizure medicine for epilepsy, and they would take Seroquel or Abilify or something like that. Merck supposedly in clinical trials right now has just one pill that combines both of them, so you would just have to take one. But other than that, I haven't heard of anything.
It's okay, we won't fight you guys.
Actually, the newest research is focused on the stomach and gut bacteria. That we have identified that serotonin, which is one of the neurotransmitters in our brains, actually the majority of serotonin in our body is found in our stomach. And now a lot of research is starting to focus on our stomach and our intestines and our digestive system and how that's affecting our mental health. And one of the reasons for that is because it's a gluten-free diet. Research shows that a gluten-free diet for autistic kids helps a lot. You might be able to speak.
Oh yeah, we do gluten-free in our house. It's hard to miss bread, a lot, and pizza, and cinnamon rolls. But, with my son, when we went on gluten-free, somebody said, they're like, oh, well, do you think that that's helping his personality? And I said, well, do you think it's contributing to his better behaviors? And I said, well, when you don't feel well,
2, or, and then move into bipolar 1?
I think it varies a lot. I think with the categories, you know, I'll be honest, I don't like the categorical approach.
More of a
I
spectrum?
think that we've gotten too specific with trying to define these disorders too much. And we're trying to fit, you know, round pegs into square holes.
Yeah.
When the treatment's not really going to change.
Mhm.
So, yeah, I think it can vary, and I think research shows that it varies. You know, some people might go 10 years where they have 3 or 4 depressive episodes in those 10 years, and then the next 10 years they have 2 or 3 manic and no depressive. So the category approach really isn't that good, and that's why they went away from it in schizophrenia, because it just wasn't working. It just wasn't a good way to describe it.
If you're medicated and you're bipolar, is it possible to make a good logical decision?
Yeah.
Okay.
It's definitely possible to do it without medication too.
Okay.
You know, I would say in the absolute throes of a manic episode, maybe it's going to be a lot more difficult. But what do you think?
Okay. Well, I mean, we actually were just talking about it, but I think honestly, when I'm in a manic episode, you know, you feel like you're in a stream of consciousness. Your brain doesn't shut off. You're just going from one subject to the next subject to the next subject to the next. When you're holding conversations with people, instead of following what they're talking about, you're constantly thinking about what you want to say after what they've said. So you can't focus on what they're saying because you're thinking about something else. So like, you know, as we were saying though, when I'm in hypomanic, it's very, very difficult for me to be rational, especially when you get more of the anxiety. You know, there's that point where you get into the grandiose, good, happy, and everything is great. But when you get to the anxiety and you're at the bottom end of it, like that's what I call it, like the back end of my hypomanic where I'm starting to come down, I'm definitely less rational. I'm more irritable and short. My husband doesn't like me very much. So,
Do you know of any studies that might demonstrate clearly any sort of connection between being diagnosed with mental illness and levels of creativity and
Oh yeah, schizophrenia, and it's one reason I like Aaron so much, because Aaron is so creative, and he always keeps me updated on his videos and stuff, and I watch him all the time. Aaron is one of the most creative people I know, and there is a direct correlation between creativity and schizophrenia. I think one of the best examples is John Nash. I don't know how many of you have ever seen the movie A Beautiful Mind. John Nash, the reason I know John Nash so well is because he actually grew up, I'm from the same town he is in Virginia, and grew up, when in college I lived on John Nash Boulevard. But John Nash was, you know, Nobel Prize winning mathematician, also suffered from severe schizophrenia, spent 6-7 years in a hospital, didn't, you know, not knowing his name or able to take care of himself, but also invented string theory, which is at the base of most of the mathematical operations we do today. And it can be creativity in anything. It doesn't have to be movies or art, or it could be math. Being creative in math, being creative in writing, psychology, whatever. But we do see that with schizophrenia.
creativity and levels of intelligence as well? Or is that,
I don't know about that.
I have a question. How does bipolar and post-traumatic stress go together? I mean, I have a friend who's diagnosed with both of them.
I think that gets into, they're finding a lot more soldiers are coming back from wartime events in active duty with bipolar. And you know, I think I mentioned the traumatic brain injury a little bit, and they believe that it has to do, because we didn't see that as much in, say, Vietnam, World War II, and one of the ways they explain that is the IEDs, those improvised explosive devices, that's being used a lot more, and that's, you know, solely how a lot of our soldiers are getting attacked, is there's bombs blowing up on all sides of them. And they believe that it has to do with the traumatic brain injury, the concussion that comes from that rattles the brain and gives you a traumatic brain injury, injures your brain. There seems to be a connection between that and bipolar. And that's, like I said, the government, I think the Department of Defense just said a couple of weeks ago, over $50 million of money they're pumping into research on the connection between traumatic brain injury and bipolar. So I think that'll be really interesting in the next 4 or 5 years to see what comes out of that. But that's where I think the connection is.
Question about where your aunt is in a community hospital, same place? Are there any of those facilities around here?
I do know there's 3 or 4 in Denver, for sure. I have not completely anybody else know about here in Grand Junction. I don't know if there's any motor therapy homes here in Grand Junction. I don't think so. I see a lot of no's shaking their heads. And we couldn't find one. I was in rural Appalachia, so where we ended up putting her was 2 hours away, which seems hard to put a family member, and it was hard at first, but after she was there for a month, we saw such a change in her that there was no doubt that we made a good decision. I mean, she really settled in and had people she could relate to, people she could get support from. And, I think the skills piece is huge. I mean, letting her go out in the community and work and feel productive and kind of earn her way, I think is a big deal for her, too.
Yeah.
I would have a question in terms of, there's obviously MRIs, brain scans, genetic research, all kinds of things that are coming up on the horizon. As someone who actually teaches and does research, is there anything you're really excited about or something you'd like to see?
The gut stuff. I think it's the stomach. I really think, and I think that and the other area is hormones. I don't know why we're not doing more research on hormones and how they affect mental disorders. Because well, I shouldn't say that, but some of us get hungry. We all know what it's like when we're really hungry. We're not in the best mood, and that might be a smaller indication. But I think the stomach research, and then when we start looking at hormones a little more, I think that's where the future of this field really is.
For a married couple, one of the spouses has the mental illness. What is maybe one thing you can recommend as far as the best thing to approach it to make a successful marriage?
I think it starts with understanding, and that's why I love doing events like this, and I love teaching this at school, at the college, because I get a lot of 18, 19-year-old kids who have never been exposed to any of this information. Their exposure comes from 90210 or whatever show, or Jersey Shore, I guess. That's their reality TV is their exposure to mental illness. So, and I find that a lot of things change with education. I find that the empathy, a lot of students come into that class thinking that mental illness is a choice and that people are choosing to act this way. And then by the end of the class, I think they get a better understanding, and I see them showing a lot more empathy and a lot more understanding. And then, I think that's the most important and the first step is understanding exactly what mental illness is, and then we can move from there.
It really sounds as though there's quite a factor related to trauma in bipolar and schizophrenia as well, yeah?
Well, actually, it can come from trauma or non-trauma. I mean, because in my case, I didn't get into any injuries, really. I was just, I definitely had a lot of stress, but it was, I don't know if I would quite call it traumatic stress. The onset of it was a little more mysterious than that. I kind of just started having hallucinations and didn't know how to handle them, So it can come from that, but it can come from just natural circumstances too.
we inherit this, so my family, I have a history of schizophrenia in my family, I have a history of substance abuse in my family, so diathesis stress model is what it is. So that's what I've inherited. So if as a child, if I would have been abused or something like that would have put a lot of stress on me, then more than likely, if I was, that stress would probably cause substance abuse or maybe schizophrenia. Whereas, bipolar might run in your family, anxiety might run in your family. So if the same event happened to her, she had a very stressful childhood, then more than likely, since it's in her genes and has been passed down, bipolar or anxiety could come out. Does that make sense?
So it's more perhaps related to the stressful nature of trauma as opposed to.
Yes, and it varies. There's not a certain level of stress. It's not like you can say, well, if you experience this much stress, then you're going to develop this disorder. It varies. My family history of schizophrenia would be stronger than everybody's in this room, and I could go through more stress than everybody in this room, but I could still not develop schizophrenia. Whereas somebody with much less of a history and much less stress could develop it. So there's just so many factors that are at play that it's really impossible to predict.
Aaron, in regards to hearing voices, when you are on your medication, do you still hear voices? And if so, how do you determine reality and non-reality?
That's a really good question. Actually, in my particular case, it wasn't so much voices as it was more my inner monologue playing tricks on me. And when I say that, I mean I had like this constant stream of like ideas coming into my head, and after a while, they were non-reality. But that was all when I was off of medication. When I tried to experiment with staying off of medication, my delusions got extremely intensified. And I got to the point where it was like I was hearing this constant stream of events, almost like a ticker tape of the news, and none of it was true. So with the medication, I rarely hear voices at all, if even. I mean, maybe when I'm really tired and I just watched an episode of Scooby-Doo or something. But other than that.
Is schizophrenia more prevalent today than it was 50 years or 100 years ago?
Yeah, it's such a hard question to answer. It's because you hear that a lot of autism, like, well, did autism just magically come around in the last 10 years because we've never heard of it before then? I don't know. We definitely know that schizophrenia has been around since we've been recording health, since we've been recording any physical health. I think that the way our society is set up these days, that mental health issues receive more attention, because if you think 50 years ago, 60 years ago, maybe you have an autistic kid who doesn't want to do anything but work on the farm. Well, that could have worked 50, 60 years ago. Now, a working farm and being able to spend time like that is kind of rare. It's hard to make it these days doing something like that. So I think the way our society is set up, where kids go to high school, they graduate high school, they go off to college, then they go out and get a job, requires a lot of independence, requires a lot of functioning on your own, and I think that's just brought these disorders more to the forefront. And we still see in more communitivistic cultures in our world, the rates of these disorders are not reported as high. Now, to me, that doesn't mean that they're not suffering from them. To me, that means that they have more family support and they're able to survive in different ways that people can't survive in this country sometimes.
So you're suggesting that as opposed to a medicinal solution or an abdominal solution, that a social solution would be more progressive?
I think that both. I think we need both.
Have you heard about healing homes in the Netherlands somewhere?
I don't think so.
Where they take people with schizophrenia that are not experiencing any success, and they have them go live with farm families, and totally turn things around. And then, have you ever heard somebody who's gone through changes in their digestion and what's happened? I will be having an audio presentation of two ladies that were at a national conference last year, and it was two just completely amazing, their physical and mental illnesses that went away or were dramatically lessened by diet. I will let you know if you're interested.
Does anybody else have any more questions?
I have a question for both Aaron and Crystal. Just like I asked him what he was excited about for the future, whether it's personally or as an advocate, what are the things that get you excited about what you do?
Well, you know, one thing that I think is really cool is that I am able to get so much work done. You know, when I first was diagnosed, I thought it was over. I thought my career was over. I thought my life was pretty much over. What amazes me is that there's enough support in existence between like therapists and Nami and psychologists and medication that you can manage your disability to the point that you can actually get back to routine behavior on your professional life. So that's what I'm most excited about.
See, and for me, you know, it's also about the recovery, and I think the other thing too is again, just, you know, instances like this today, the fact that, you know, all of you are able to come and are willing to listen and educate yourselves about mental illness. I mean, just the receptiveness of the community, being able to branch out and understand so that we don't live in the dark ages of mental illness and what it used to be. I mean, having compassion and understanding about these sorts of things, I think, is only going to make it progress further into a positive light than a negative, and that hopefully, because we have more positive thought, we'll find more progression on things that we can do to help. You know, I just think that this is great. I really appreciate the answer from here.
Likewise, thanks.
Yeah, let's give them a round of applause. So this is a lot of what NAMI's about. We're about education, we're about support for individuals living with mental illness as well as family members. And really what we see is once we start to educate ourselves, once we start to gain support, then we do become advocates. And we do get to step out and talk about what's going on with ourselves and with our family members. And you'll be amazed, as soon as you start talking, you think you might be the only one, but as you start talking and opening up, you will just have so many conversations, and we have all found that it brings a lot of freedom in our lives. So we hope, regardless of why you're here, that you have found something that you'll be able to take away. But we also hope that if NAMI can serve you in some way, that you would definitely find out about how we can serve you. We do have support groups once a month. We do have the family-to-family course, which you've heard a lot about. I think anybody that's gone through family-to-family will bend your ear for a while about how it changed their life and maybe even changed their loved ones' lives. So back in this back room, we do have information about that. Another really great thing about our panel here, Aaron and Crystal are both in our own voice presenters, and so they actually have a presentation that they do together, and sometimes with some audio visual as well. They are able to come to your events, to your organizations, to your churches, your nonprofits, whatever group you're a part of, and share their information, very similar to what you've heard today. And so that's just another way to be able to educate people in our community and in your groups. Also, Dr. Jones has graciously become the sponsor for NAMI on campus at Colorado University. This is phenomenal that we're going to have this in Colorado. They have worked really hard already with students and with his leadership as well. And we're just hoping that that's going to gain momentum, and hopefully in the fall we'll be up and running. And so this is going to be, is it the first in Colorado? Or
Yes, it's the first in Colorado.
Yeah, it would be the first NAMI on campus in Colorado. So it's just amazing to see, you know, NAMI is totally run by volunteers, nobody gets paid. Everything we do is free, all the support groups, all the family-to-family are free. The way that NAMI Western Slope makes itself available to people is through membership
I know, but no, I
Don't say I never gave you.
Dad? Thanks for coming out. Thanks for coming out, Dad.
Well, I'm.
Yeah.